On your study where you had the decrease in the A1C from 7.7, thank you, to 7.1, I noticed there were about 2 or 3 people whose A1C actually went up. Was that a result of insulin resistance and maybe lowering their insulin too much, or any and the implications of that? I have some ideas, but I wanted to put it out to you.
Yeah. Those 2 people, their HbA1c went up. Actually, sorry, I believe one person, their HbA1c went up, and then one person, their HbA1c didn't change. But actually what we found with those people is they were really struggling with their their insulin management. So I think with one of the participants in particular, they really just cut back on way too much insulin, and their blood sugars went up quite significantly. And with that particular participant, we eventually got their insulin sorted. I mean, our study wasn't to change insulin management, so to speak, but we did give them education on how to do that and some support. Eventually, we got this person some individualized support, and at the follow-up time point, so at the 24-week time point, their HbA1c dropped to about 6.5. So it started at around 7, went up to like a 7.5 or something during the study, and then it came down to a 6.5. So they actually loved the diet, they just struggled with insulin management.
Thank you.
Hi, my name is Roxana Söderberg. I'm a metabolic health practitioner. My question is for people with type 1 diabetes. What ketone level does concern you when they go on a low-carb diet? I know, like on a standard diet, if it was 1.3, I was supposed to go to the hospital, and not on a low-carb diet, obviously.
That's for me. So I think that our ketone level has to be interpreted in the context, right? The reason why they send you to the hospital with a level of 1.3, if you're expected to have a level of 0, that means there's a change from baseline. It means there's something wrong. And if you're eating carbs, the only other thing that could be wrong is that you didn't get your insulin, that your insulin didn't get work, that your technology broke or whatnot, right? It's a bit harder on a ketogenic diet because I don't know what a person, so I personally like for my patients to know their baseline. And by that logic, that I can know if their ketone level is significantly higher than their usual, then I worry about them. Not to the point where necessarily sending them to the hospital, but to the point of trying to troubleshoot and see what's wrong. Is there a problem with equipment, with insulin? Is there any other concerns? Certainly if the ketone level is out of the range that I expect someone might achieve with a nutritional modification, that would also worry me. But remember, usually you check your ketones in the setting of having a higher than expected blood sugar, vomiting, feeling ill, not being well. So in that setting, I think a ketone level is more often a sign of a problem than just a nutritional modification.
Thank you.
Mm-hmm.
Mark Cucazella from West Virginia University in the VA hospital in Martinsburg. Something that was taught to me, but I'm not sure, Jessica or, Belinda, if this is absolute. It was told that the beta cells don't have stem cells. So when people have type 1, that doesn't recover. But I had a curious adolescent come in this year after a severe COVID infection. He was diagnosed with type 1, A1C of like 10 and all the classic features, and his C-peptide was like 0.2, and then he found his way to my clinic, and we put him on a Bernstein type of program, and glucose, he came off his insulin, and he was on like 50 to 100 units. He was an athletic adolescent, kind of like a Dykman child, but his C-peptide came back to 5, and I believe he's still off of the insulin now about 2 years later, but with the infections, and type 1's not autoimmune, are you seeing anything like that? Or is that, the beta cell recovery, what is the status of that in some of these kids?
Yeah, so, we see a fair bit of recovery early after diagnosis. Like usually, the autoimmune process in type 1 diabetes is something that happens over the course of years, months to years. So they've had autoimmunity for a long time before they're diagnosed. And at the time of diagnosis, kids have about 20% of their beta cell capacity left. They just can't overcome the chronic hyperglycemia, and they become very symptomatic. So what we see commonly in all kids, or in many kids with type 1 diabetes, is once you put them on insulin, their blood sugar normalizes, that they can dramatically reduce their insulin doses and have much more stable control for a couple of weeks, months, sometimes a year, or sometimes longer. And some kids do come off insulin even without going on a low-carb diet. And so that we call that diabetes remission or a honeymoon period, where you get them healthy enough for their remaining beta cells to be able to do the work. And that's how some of the immune modulatory drugs work too, right? Like there's recent drug discoveries where you can use immune-changing medications, teplizumab, to slow down the immune process and try to keep that period go longer. So I don't think it's necessarily like a new, like coming back of beta cells, but it's a recovery of the ones that are still left. And then the big question is, how could you prolong that? How could you keep that going? And I guess it makes sense to me that on a low-carb diet, they could be off insulin longer than on a high-carb diet, just by the plain logic that they need much less insulin, so the 20% beta cells they have may be enough to make the amount of insulin you need on a low-carb diet, but may not be enough to make the amount of insulin you need on a high-carb diet. But there could be, and that's why I'm doing this study, there could also be additional effects on the immune process and on the immune system, like anti-inflammatory beta cell milieu changes that could be additionally helpful. And that is what I'm trying to answer with the upcoming work.
What percent are antibody negative? This kid was antibody negative out of the kids you see.
Yeah, so that happens. I think that it happens that we have. Then you wonder, is it type 1, is it type 2, is it antibody negative type 1, or is it antibody positive type 2? Like, it's all kind of a spectrum, and it's a little bit of a confusing bucket. I have seen a few patients that were antibody negative where it was convincingly type 1. But usually you think, you want to make sure they don't have like MODY, maturity onset diabetes of the young. They don't have type 2 diabetes if they have obesity and insulin resistance. It's a bit tricky, but it's not, I can't quote you a number, the percentage, but it does happen even with type 1.
Oh, thank you.
Mm-hmm.
Can you explain what the honeymoon period is for type 1s?
Yeah, so it's kind of a interesting name, right? So people call it the honeymoon period, and that's just that time after diagnosis where people need a lot less insulin or need almost no insulin or no insulin at all.
So that's pretty common.
It's pretty common, yeah.
And the reference, I think, is to marriages that have a good honeymoon and then it fails or something.
Yeah, it's, yeah, so that it is called like that in the literature. I promise I did not make it up. But it's just because it's a time of relative ease. Like, it's much easier to take care of the diabetes. You need much lower insulin doses, and you could be less precise, right? Because the majority or a lot of insulin is still made by your body, and you just need to substitute a little bit rather than replace it all.
So what if, in Dr. Cucuzela's case, the person cuts carbs for the rest of his life, so he never needs as much insulin as he did before, and he would never have type 1?
Well,
or it's honeymoon period. Well, so I'll joke or say, do you have a crystal ball?
I do not.
Do you really
have a
know?
crystal ball.
No. Most endocrinologists do. It seems to me.
Yeah.
And it's like they're predicting the bad results that they see in their other patients and project it on to.
Right. So to answer your question, I think that even if you eat carbs, sometimes kids come off insulin for a while, so they can make enough insulin to even cover the carbs that they eat. If you don't eat carbs and you need much less insulin, you could make, presumably, you would need a lot less beta cells left, and that honeymoon could take a lot longer. Is it going to be forever? I don't know. But
another big difference, once someone becomes an adult, we don't talk about milligrams per kilogram or anything like that. Suddenly they're an adult. I had a patient who was 6'10", and do you know what the blood pressure is of giraffes?
No.
210 systolic. And because you need to get the blood pressure so high. So what about the heterogeneity and individual variability in the pancreas size and the ability to, what if you just dealt with a small pancreas? And is this something that we don't really ever measure, right? We always measure the output of the organ rather than the size. So it's like you have to have this functional test of a carb load to see what your blood sugar, or you have the C-peptide measurement. Although I measure a lot of type 1s who say they're type 1s, and their C-peptides are not zero.
No?
What's going on there? Well, other than they don't have antibodies either. I mean, so the C-peptide never really goes to zero. Is that right?
How long have they had diabetes?
For years.
For years, yeah.
Yeah.
Yeah, maybe.
I wonder if they're misdiagnosed. Now this just brings up there's a question. But if, let's say there's a temporary reaction that makes the beta cells not make insulin, the honeymoon period really is kind of not necessarily something that has to then become worse again. I don't know. So if it was COVID related or infection related in that case, then it's not developing the autoimmunity after the fact.
Oh yeah, right. So maybe you destroyed a certain number of beta cells and now you've stopped the process because the COVID is done and they're going to maintain whatever they have. Yeah, I think that's
plausible.
It's plausible.
Wow. Yes, there's
forgot
a
my
light,
question.
so it's hard to see. Yeah, just take the mic, Dr. Wolver.
Sue Wolver, obesity medicine physician. So for patients with type 1 who want to consider a low-carb or ketogenic diet, do you recommend that they monitor their ketones? If so, when, for how long, and with what modality?
So it's my personal preference that they do, and not because I want to know what that level is, but I want to know when they call in sick with emergency, I want to know if they're reasonably close to their baseline, right? Because it takes me down, like, so the paradigm we have in medicine is like someone vomits, has an unusually high blood sugar, or doesn't feel well. They're supposed to check their ketones to help distinguish if it's just a stomach bug or the flu, or if they are going into DKA from some type of problem with their equipment or medication. So the ketone level in that situation helps me say, okay, you are sick, but you don't have ketones, so you just have the flu. Or you are sick and you have ketones, so I worry about your insulin. And if I have someone on a high-carb diet, if they have ketones, it's a problem. If they don't have ketones, it's not a problem. But for a low-carb diet, it's much more complicated because they may just have ketones because that's what they do. So if the person
They're
says,
running on ketones.
if they say, I'm sick, my ketone level is 2, but I'm always 2, I'm not going to worry about their equipment as much as I would if they come and say, look, I usually run 0.5, now I'm 3, right? So for that reason, I do like people to know their baseline, and but I don't think they have to do it all the time, like, fasting ketone measure here and there, just so that they kind of get a sense for what their ketone level is.
By blood?
I like by blood because urine is not that helpful. Urine is more of a qualitative, is it there or is it not there, and it lags behind several hours after it clears. So if you can by blood, but if it's not available, I think urine is a good second.
Thank you.
Kathy Tracy, Obesity Medicine, Southwest Louisiana. My question is whether it's by way of a high fasting insulin in an insulin-resistant patient or a basal insulin rate in a type 1 with the pump. Do we know what level of insulin prohibits lipolysis?
Do we know?
Great question. It's taught that one of the most powerful factors to turn off lipolysis or fat burning is insulin, and the carbohydrate insulin model of obesity is related to this. What about the quantification? I mean, the easy answer would be it depends, right?
It depends on how insulin sensitive you are, right?
Yeah.
But I do think there is some evidence that people with type 1 diabetes have higher insulin exposures at the peripheral tissues and levels, and I think that you could measure, like you could, wonder free fatty acids, for example. If a person without diabetes fasts overnight, they'll have higher free fatty acids in the morning, where they may not drop as low for type 1, where they have the constant insulin exposure from the long-acting insulin.
I remember there was an in vitro study, Volek presented it a lot, I borrowed it from Jeff, where the serum level could be as low as 8 insulin in the way we measure it, and that there's a graph where it shows the lipolysis of that cell went almost down to none.
Mm-hmm.
So, and that doesn't extrapolate perfectly to a human, but it means that at very low levels of insulin, you might be getting anti-lipolytic effect. You might get the fat blocking effect at much lower insulin than even that's in the normal range on our lab tests, right?
Mm-hmm.
Corey Cedar, data point in Dr. Lentz's study, and diabetes coach with Diverge Diabetes. I had a question for, I guess, all three on the panel, because what I kind of experience being a person with type 1, when you're looking at your study result with your 18 participants and you see that you have carbohydrate reduction in your patients, but then you also see 2 of those 18 patients have their A1C actually increase. What that suggests to me is that and just kind of through experience, it's not a fair comparison between your studies and the standard of care, which is providing nutritional support and insulin management techniques and tools, because there's a dearth of knowledge as far as insulin management techniques for a low-carb approach. So, I could start with just how do you dose for protein as a fantastic example of nobody really knows until they go through Bernstein. So my question is, how can we standardize your comparison so that we can give you a fair comparison? Because you're just doing the carbohydrate restriction. How can we, as patients or as motivated participants, improve the quality of the research so that we can fight the fight with 2 hands rather than just the carb restriction hand, because it is still a pharmaceutical required condition?
I think that question is pointed at me. I will add something to that, and then I'm sure Belinda and Dr. Westman will as well. But it is a really good point. I know for our participants in particular, they, as I said, they had type 1 diabetes for about 21 years. And for a lot of them, they had all this education up front. Some of them didn't even personally receive the education. It was their parents that received the education, not them. And they had found their own unique way of managing their diabetes. And I think as well, a lot of participants that were joining our study were just a little bit, I guess, dismayed in terms of what was available to them in terms of education around diet, but education around insulin management too. We didn't, as I said before, we didn't necessarily make insulin management a huge part of our intervention, but as you know, you can't change diet without changing insulin. So we actually found that we were having to, step in with our diabetes educator and provide a lot more support than we anticipated, because as you said, a lot of people had no idea about the fact that protein could raise blood sugar levels. So we only had a 12-week intervention period, and there were so many things we were needing to educate these participants on. It wasn't simply just a matter of saying, okay, let's drop our carbs now, and you're going to change your insulin based on your carbs. There was so many other factors at play. And I do think, as I said before, for those participants where their HbA1c didn't reduce in the 12-week period, that's because there was so much education that was required, and 12 weeks isn't always enough time to get your head around that. So, what we did in our study was we provided educational booklets that were quite detailed, and we caught up with our participants every 2 weeks. And that's something that's difficult to replicate in the real world. I mean, we had time because it was our research study, but I think we do need that, really close support from healthcare practitioners with patients when they are trying this, especially in those initial weeks. Our study published in PLOS has all of our resources available, so practitioners can use those in their practice. But yes, it's a really, really good point. There's so much to think about when you're going low carb for type 1 diabetes. It's not as easy as the other conditions.
I'll second with what Jessica's saying. So for our study, the one in the adults that's ongoing and kind of wrapping up now, I partnered with Carrie Deulis, who's a physician living with type 1 diabetes and following a very low carb approach herself. And so she helped me develop some protocols for protein coverage we, as I mentioned yesterday, we said we would consider 2 to 3 grams protein equivalent to 1 gram carbohydrate and cover that with insulin similar to the carb ratio, but give it over 2 to 3 hours to kind of account for the duration. So that's something we came up with for this study, because the truth is you need to find a standardized way. And then we met with patients once a week to kind of talk about how that's going, make sure that they actually did do that, and adjust as needed if it wasn't working. So we took some care, and Carrie looked at all the study protocols before we put them in. And so I think it's patient-informed research, right? If you want to do something like that, you want to ask people who do it, how they do it, and how it could work. For the current study I think the major challenge we have is that the people who have lived with diabetes for years and are on a standard diet, they felt very uncomfortable with our study glycemic targets and with the way that we corrected for hypoglycemia, because we did recommend to target for a blood sugar of 100. That's really honestly quite probably the lowest you can, if you do a controlled arm, low carb versus standard carb, and you tell one group to aim for 80 and the other one for 150, no one's going to buy the results. There's yes, they had lower blood sugar because they targeted lower, right? So you can't really get the point across. So you have to find a way to standardize somehow between the group. But anyways, the participants, a lot of participants didn't even feel comfortable targeting for 100 after having lived for so long.
It was too low.
The standard, because we recruited people who are not on a low-carb diet, and we told them to set their target at 100, and then I would look a week later, and they're the targets aren't 10. And they're oh yeah, I turned that up. I didn't feel comfortable with that. So I think that, and then the other thing, treating hypoglycemia, you tell them, like the Bernstein book, minimal amounts of glucose to correct hypoglycemia. It's really, really hard to get people to do that in the real world if they're used to eating 15 grams glucose for every episode, and then you tell them eat 4. Very hard. And so I think that, but it does answer the research question in a way. It's one of the questions is how can we bring this to patients? Can I, as a medical provider, bring this to my patients? And it's hard.
Well, Jessica, Eric here, I want to just comment. You made reference that it's easier on other types of diseases. No, it's not. So, best I can tell, the carb level that you were studying ranged maybe up to 75, or yeah. So, for adults who are trying to lose weight, reverse diabetes, it's easier to go to 20 or less total carbs per day because the hunger goes away. So it's easier to leap all the way over to nutritional ketosis because you're not struggling with sugar and ultra-processed food addiction every day. So I would urge you to include interventions that have the whole range of carb intake. Now, that Harvard group, Belinda, David, Ludwig, use low glycemic diets, and I mean they can work, but if you're trying to help someone get perfect glycemic control, what we learned from Bernstein and Keith Runyon and these other ones who have diabetes themselves is it was easier long term for them to stay very low. And I think it's because you're going to get the appetite suppression. We even heard that yesterday, that some of the parents of the children had to kind of push their kids to keep eating when the carbs are really low with type 1 diabetes, with excellent blood glucose control. Anyway, I just wanted to comment. You think of it as a dose response. A 75 gram per day is not as strong as 50 gram. It's not as strong as 20 gram per day total, not net. And that's the way I think of it for obesity and type 2 diabetes. The most blood sugars are very, very sensitive to very small amounts of dietary carbohydrate. I would think this would extrapolate for better glycemic control and even better adherence the stricter you are. I mean, even I'm getting people coming to me on this thing called the carnivore diet. Have you heard of it? They're not eating any carbs at all. I mean, so carnivore to me is low carb. It's a subset. It's not out in this, by itself over here. You're limiting carbs, and a lot of people find it really easy because they're not struggling with the daily onslaught of sugar and trying to avoid that, especially here in January after the holidays in the U.S. I mean, carbs come out of the woodwork. So anyway,
I will agree with that. I'll just say, actually, we had a participant, because our range was 25 to 75 grams of carbs a day.
Right.
And the participant who really embraced just cutting all carbs out, he was like, oh, you're saying I don't need to eat carbohydrates for my type 1 diabetes? He ended up eating about 20 grams of carbs a day, and he was the participant that saw the greatest drop in his HbA1c. It started over 8 and it fell to about 5.8, and he's still in touch with me now, and it's in the low 5s. And for him, it's just super easy. And you're right, for a lot of the other participants who didn't restrict their carbohydrates as much, maybe they were about 50 to 75 grams per day, they still saw improvements in glycemic control, but I guess struggled a little bit more with the diet itself and insulin management and so on. So I absolutely agree with you.
I'll talk to my patients and say it's like taking a Band-Aid off. Well, I guess if you have a hairy arm anyway. You want to do it fast. You want to get the carbs out fast. It's easier than the struggle of slow Band-Aid removal.
But to answer your second question, how could people help? I do actually reach out to people who live this when I plan my interventions, and I work with Andrew Kutnick on this one. And I'm going to talk to Beth McNally about her intervention. Like, how do you get people to do this, right? Is one of the things I'm struggling with. And then we talked earlier, like, what are some of the foods that are diabetes safe? Obviously meat, but what if I have a participant that wants to eat a bar or that wants to eat certain products? Like, how can I make them succeed without having to ask them to not, to bring a steak for school lunch? And so I would love, I'll do those things, right? I'm right now planning a study for kids, so if anyone has thoughts or resources that they think I should use, I will actually use those. So any help, welcome.
At least you'll look at them.
Yes.
Maybe use them. Fantastic.
Which is kind of useful.
This is the real world end user academic influence that needs to happen.
See, I can't make this up, right? Like I'm planning an intervention to do this or that, and what I'm doing, I can't make up what you guys have learned over years and decades. So, yeah.
Next,
Professor
Rob.
Westman. Hello. I'm Rob Sivas. I'm a metabolic health specialist. I'm going to take a little bit of umbrage with something that you said. I loved your talk, but you said that diabetes is not caused by a lack of insulin. I would say it absolutely is. The reason fat people don't have diabetes is because they can still produce more than adequate insulin to clear the sugar from their bloodstream. Insulin resistance is not an insulin problem. Insulin resistance is a blockade of a receptor. Elevation of your hemoglobin A1C occurs when you run out of adequate insulin production. So for my most obese patients, they often have the lowest A1Cs because they can produce overwhelming amounts of insulin. And it's only when they stop being able to shove that sugar into their cells, fat cells in the liver, and make fat, that their blood sugar starts to rise and their A1C goes up. Well, if those people magically could produce more insulin, their A1C is going to stay low and they're just going to get fatter. So why then, if we look at diabetes, if we look at a rising A1C, it doesn't matter, all-cause diabetes.
Well, we're talking type 2 now.
Well, no, we're talking about every type of, because type 1 diabetes, type 2 diabetes is a lack of adequate insulin to clear blood sugar. Type 1 just doesn't make it. At type 2, the blockade is too
What
great
if you
for the-
didn't introduce all the blood sugar?
Well, no, but I'm not going to go there.
I am there.
Right, okay, no, let's go.
Don't put it in the system.
Let's go there. Because even in our patients early on, and we're talking about that early phase, the first 6 to 8 months of treatment, maybe the first year of treatment, the insulin resistance that they all have because they've been eating a lot of carbohydrates, whether you're a 1 or 2, a LADA, a monogenic, it doesn't matter. Their insulin resistance is greater than the capacity to produce insulin. Okay, so the starting point is to level the ratio of extracellular glucose to intracellular glucose because there's a mismatch. And all too often what we do in therapy, in this ketogenic space, is kumbaya, you're on a low-carb diet, let's deprescribe. But that doesn't fix the insulin resistance. It takes a long time for that to get
totally
better.
disagree. But let's take this for another.
No, we'll because in the talk we'll show our data about going up on insulin to begin with,
I totally.
and then coming
Well,
down.
we're both board members of this
Yeah,
organization, by the way.
But that's
You're
something
wrong.
and I just texted somebody else to say you're wrong, because
No, that's okay.
when we deprescribe too early, there's a recurrence, a resurgence of the diabetes.
This reminds me of when I go to the mechanic. I don't want to know what he's doing now. Just tell me it's fixed. Tell me the blood sugar is normal. Tell me the human's doing okay. And I just need to know enough to explain to my patients. My point was that the people are coming in saying diabetes is an insulin, but there's not enough. Okay, fine, but that doesn't help the patient understand that it's the food that's the cause. That was the point.
I'm not talking about the patient. I'm talking about the provider. I'm talking about the provider.
Me too.
The provider should not be deprescribing until the A1C starts to come down. Not the blood sugars, the A1C.
Oh, well, okay, this is fine-tuning the management.
Yeah, absolutely
wow,
it
okay.
is. But a lot of folks tend to deprescribe very quickly. Oh, I was doing low carb for 3 weeks, I'm off my medication. Or I stopped my medication early. And then 5 to 8 months later, you see that resurgence.
May I suggest we have a pre-course on deprescribing
I think that's a very good idea.
and come up with some sort of guideline, because you're wrong.
No, well, we'll discuss our 1,093 type 1 diabetics that used our protocol to get an A1C of 5.3 and maintain it at 5 years.
Reason me this then, after weight loss surgery, after they stop all the medicines.
For a little while, and then guess what? I'm a weight loss surgeon.
I know.
Right, and 3, 4, 5 months later, they get a rebound. But nobody's looking at them because kumbaya, you're better and you're losing weight.
Well, they're not a surgical problem then.
No. But we'll discuss that in detail, and I'll go through. I'm just kind of setting up my little talk.
All serious.
But I want to ask Jessica a question. You've got a bump, am I right? Or Doug said you had a bump.
Had a what?
Sort of.
Oh, well, we all know. Are you following a low carbohydrate or carnivore diet with your bump? Are you managing your pregnancy in a different way?
Could you translate that? What you're asking? As
Doug mentioned. Doug let the baby out of the bag, and it's out
You
now.
guys know before most other people, so that's fine.
Right. But the question is, have you now knowing that you're pregnant or being pregnant, planning it? Have you planned to eat differently? Have you put literally your mouth where your research is in terms of changing your diet, knowing about growth and development of babies on a ketogenic or a low carbohydrate diet?
Well, I personally have been on a low carbohydrate diet for over 10 years. It's been really helpful for my mental health, my physical health, and improving nutrient density. And honestly, it's simple and it's the way I like to eat. I am still on a low carbohydrate diet, now being 18 weeks pregnant, and I don't plan on increasing my carbohydrates necessarily. My biggest focus is getting enough energy, getting enough protein, and getting enough micronutrients, which I know I can do on a low carb diet, so I don't have any concerns about that.
Good, thank you.
Wow. Jessica, do you have the book Type 1 Grit Pregnancies yet? Maybe we can send you a book on the women who've had had keto or low carb pregnancies and also type 1 diabetes. There's a book, the author is here in the audience who wrote it, and I just gave her the eye that she should send you the book.
Yes, please.
That's great.
I'm Denise Force, an endocrine nurse practitioner from New Jersey. My question is, so do you feel that perhaps the lack of enthusiasm for the low-carb diets isn't so much about the thought of sustainability or maybe complications in the future, but rather just carb addiction? We are all addicted to carbs. They're delicious. We love them. In my population, we've been able to get people to do low carb, and they don't stick with it. How do we overcome that? It's addictive. Or do you believe it's addictive? I mean,
Yes, absolutely. I mean, I'll take the first crack at it. There are 2 textbooks now called Sugar and Ultra-Processed Food Addiction, and I've learned a lot from Dr. Vera Tarman, who has a book called Food Junkies. She's an addictionologist in Canada, has a wonderful group associated with that, and she applies basically all of the addiction principles to food and sugar specifically. And so the problem is most people don't have it. Or so alcohol is frequently consumed, and there's alcoholism, right? You wouldn't give an alcoholic alcohol, and it's in social circles it's taboo, it's against social etiquette. But we have sugar addicts all over, and we give sugar to them and encourage them. Maybe that'll be different in 20 years, but clearly there are people who are addicted. And as we're doing these protocols, that's erased, right? I mean, so it's usually 50 carbs without Skittles and Snickers bars and without highly refined sugar. And so in the research, there's overlap between even, vegetarian or meatitarian types of diets, because we all minimize that sugar and ultra-processed food. And that probably is the number one reason for relapse back. Imagine if you had a little alcohol on every desk at work, and you were an alcoholic, and and it would even be enabled that you should have some, and how could you live without it? So I've changed in my thinking over the last 5 years. Went back to a obesity medicine meeting, and one of the doctors said, "That's the first time you had sugar addiction." And I said, "Really?" Anyway, we don't really have long memories for times when we were wrong, do we? But is there sugar addiction, and how does it play out in kids?
I buy it. I just participate in the rewriting of a book, like a revised edition on food addiction, and I wrote a chapter on carbohydrates and how they play into it. I think, there is lots of reasons why that would make sense. Like carbs stimulate a lot of the same brain areas as nicotine and cocaine, and when you offer rats the choices of cocaine or sugar water, they would often choose sugar water over the cocaine. And a lot of the addictive foods that have been linked to food addictions are foods that are high in carbohydrate. Interestingly, the early days of food addiction, was described in the setting of eating potatoes and carrots, and so everyone's like, well, that's not a carb, but wait a minute, those are carbs, right? And so I think it makes perfect sense that could be the case, and it would be very difficult to overcome, because if it's all present, right, and it's not as easy to eliminate. Usually the treatment for addiction is elimination and removal from the environment, and that's a bit difficult for food.
Or we treat it with a drug. Jessica, any thoughts about food addiction?
I agree with both of you. I think speaking from experience with people who have type 1 diabetes and people who don't have type 1 diabetes, I think one thing that helps when it comes to addiction to carbohydrate is being able to eat proteins and fats to satiety. And when you look at the research investigating low-carb diets for type 2 diabetes, the overwhelming majority of prescriptions is eat fat and proteins to satiety. And I think people that really embrace that message, and sometimes you've got to like really drill it into them that it is okay to eat as much as you want of those recommended foods, at least at the beginning, I think those people find it a little bit easier to overcome food addiction and cravings for carbohydrates, because a lot of the time your body is craving that energy. And fats and proteins are particularly satiating. So in our study, we did recommend participants eat protein and fat to satiety, and we found that to be quite helpful in overcoming addiction to carbohydrates.
That reminds me, yesterday, in some of these families with type 1 children, or could be a parent, there were some delicious looking mud cakes being made with non-sugar sweeteners. I think those are fine. Metabolically, in adults, I need non-sugar sweeteners to get people off of sugar. If I meet the sugar addict, and they're not, I get them onto methadone. If I get a heroin addict, I get them onto methadone or Suboxone maintenance, some other drug. So I think of using a non-sugar sweetener as a way to get people off it, and yet satisfy that craving and all. And the practical approach that I've learned, that works pretty well. And you can say, oh, but aren't those bad for you? Not as bad as sugar. And so just be persistent with your patient, but I think give them alternatives, the substitutions for the pasta, shirataki noodles, the cloud bread. There's even a company now, cloudbread.com, cloudbreadcompany.com. Remember where you used to make these meringue-like things, whip up the egg whites, put it on the cookie sheet? There's a company that'll send it to your door now, along with the cheese crisps and the pork rinds. There's a Pork King Good company that'll send cinnamon-flavored pork rinds to your door. Anyway. The substitution is real. Oh, then the cauli rice, mashed cauliflower. Although most people kind of get tired of zoodles, they're tired of making their own zucchini things. So check out the Miracle Noodle, Pasta Zero, Skinny Pasta. Those are the alternatives. I don't know. The food I saw yesterday among the families with type 1s, that looked fantastic, and they had delicious things.
Good afternoon. Stu Weinstock. I'm a psychologist and a ketogenic lifestyle coach. And Dr. Westman, thank you so much for End Your Carb Confusion. I love your book. I recommend it to all my clients, first and foremost. Question for you. Let's keep it very straightforward here. With appetite suppressants on the market, like Mounjaro, other medical apparatus where people are trying to get a quick fix on weight loss. Can you comment on that, what the side effects are with Mounjaros of the world?
Well, they're also being used for diabetes. I'm not sure with type 1s, though. I wondered is that incretin system still operating normally if someone has type 1?
It's all,
GLP.
They're not indicated in type 1, but sometimes we do use them for people who need very high insulin doses, and it does reduce insulin doses.
Yeah, I saw that in anticipation of this meeting. But in general, for weight loss, well, first for diabetes, it's great that endocrinologists have kind of bumbled upon a medicine that causes weight loss for diabetes and not insulin that causes weight gain in most people, because it'll treat the underlying obesity. I just explained with a patient coming to me that there are alternative ways that work, and there are safer ways, there are less expensive ways. There's a lot not known about semaglutide in all of its different forms and these other medicines. And so if you want to do something that you take on a little bit of risk, I'm probably preaching to the choir here that something goes through FDA approval and you start putting it out into does that mean it's safe?
That's right. That's right.
It goes through minimal safety evaluation, really.
And the hard and fast rule is if there's no longitudinal studies to really back up these medications, that would get me a little bit anxious to
Well,
go
you
with
know,
them.
I'm happy that pharma is in the obesity medicine space, because obesity and type 2 diabetes, which often go together, I know it's not always, but are legitimate problems that need pharmacologic help in our current day society. Now, food itself can do all of this, just not most people will or can do it. But no, I'm now in my own practice at Duke saying, well, you know, you want to get one of those drugs. It's really it's kind of, there's an art to it now. One of my colleagues gives out a Zofran prescription, which is a prescription drug for the nausea that the medicine might give you like 2/3 of the time. And so if you want to have if you want Ozempic, Saxenda, Zepbound, and Mounjaro, I say go down to see Dr. So-and-so down the street. I'm really focusing on the lifestyle changes. And after people, because he's out in private practice in town, he's cash on the barrel. And so if someone starts saying, well, that's a little too expensive, then they come back to me, I'm insurance pay. And then they get tired of me being so strict about the diet, they go back to him. So anyway, one of my friends who was an internist, a teacher, became a weight loss doctor. He said, you know, there's some people, the first thing you do, you tell them to do something, they want to do something different. You know, or maybe it's just pure addiction. Yeah. Was that helpful? I'm not prescribing that stuff, but there are a lot of doctors in my area that are. Yeah. So, and Jessica, any comments about these new medicines?
Yeah, a lot. I mean, most patients that see us in clinical practice want to lose weight. And over the last 12 months in particular, you know, a lot of their doctors are prescribing weight loss drugs like Ozempic, I guess, just because that patient wants to lose weight. It doesn't matter if they've tried something or not. And what I find the biggest issue with those weight loss drugs is because they are suppressing appetite, people essentially are just going on a very low calorie diet. They're not really thinking about what types of foods they're eating. They're just eating a whole lot less. And even though it is achieving weight loss in some people, we are seeing that a lot of that weight loss is muscle mass. And then because they're losing muscle mass, their metabolic rate is going down. And then when they try to come off the medication and they haven't learned how to eat properly, then it's a recipe for weight gain, and they're going to go into that cycle of yo-yo dieting and yo-yo weight loss, weight gain. And so I do find that those medications get in the way for people who actually do want to change their lifestyle and achieve long-term weight loss. And unfortunately, because they do achieve short-term weight loss, people are really keen to try them, but I do urge people to think about the impact on your lean tissue and your metabolic rate.
Those are great points. They censored me. Those are great points. And the idea that there's something called the locus of control of health, means you need someone else to fix you. And you can't fix yourself, really. You need to be operated on, you need a pill or a product or something. And these just kind of play into that idea. The drug will do all the work. A lot of doctors aren't even telling people what to eat. And that is, I'm glad you mentioned that. There is a safe use of low-carb diets and low-calorie diets. And if you get really, really low with a weird perturbation, meaning not much protein, you can lose the muscle mass for sure. Even then, the human body is so resilient, and we're learning so much. You know, despite things like weight loss surgery, people survive. You know, you make the stomach this big, you reroute the intestines so that things are not timed at all together, eating and the digestive juices, and people still gain weight, even though you've done that major change. So, yeah, I'm not super worried, like fear-mongering about the risk. It's just you want to put that into the equation of what you want to do.
I think those medications are part of the repertoire of choices that people can make, right? And not every patient is going to be able to succeed with just diet or just lifestyle changes. Some patients choose surgery, medication, lifestyle, and on that spectrum, I think I do prescribe those medications, but only ever in conjunction with a lifestyle intervention, and found that for some people it gives them the edge. It just helps them make that transition that they were before not able to succeed with.
I often use the metaphor of learning to ride a bike. Sometimes you don't get it the first time. Well, most of the time you don't get it the first time. It's the second time you might fall over, and so someone will come back over the holidays, well, I ate some carbs. Well, just pretend you're starting over, like you're riding a bike. You'll learn this time, And my colleague, Will Yancey, is like, yeah, no one can do it long term. Here's a pill. Go ahead. No one can do it long term. So part of it is the style of the doctor of giving up, like when you said, some people need the medicine. No, they don't. So in the office, if I'm going to be motivating, I'm going to often use the bike riding metaphor. It fell down once when the woman looked at me and said, "Doc, I don't know how to ride a bike." So, but then another one that a colleague of mine uses is it's like learning to play piano. So you got to work at it every day. And you have a leader, you have a teacher side by side showing you what can happen down the road. But some people, it's like working at it every day. That's the addict model, really, the addiction model.
Thank you. I'm Cynthia Myers-Morrison, and I'm a food addiction professional and I'm a board member for Food Addiction Institute, which is a resource for all of us as well. And the question I have is with regard to the intergenerational impact of these diseases and of the change that can be made by being at a healthy weight and healthy mindset prior to conception for both males and females. So might you address that, and how can we get that kind of information into the population?
Any thoughts? This is an area for research.
Yes, kind of call a phone joker. Pardon? I'll call a phone joker. We'll call it a phone joker to ask someone smarter.
Okay, so we'll have to ask someone. Jessica, any thoughts?
If I understand the question, was it about being at a healthy weight prior to conception and the importance of that?
Yeah.
Yes. And how do we get that information to the generation that will be conceiving?
Right,
with
okay.
Type 1, type 2, et cetera.
Yeah, okay. So I think probably the most important thing, at least what I see in practice for being able to conceive and having a healthy pregnancy and reducing your risk of pregnancy issues, but also complications with your baby, is energy availability. So energy availability is about your body's ability to utilize energy, stored energy that you have, but also energy coming in. And at least in my practice, I do see a bit of an issue with people not consuming enough energy, and the energy they are consuming is the wrong type of energy. So they're ending up in a situation where they are obese or overweight, but they have low energy availability. They have low metabolic rates. They might also be nutrient deficient, etc. And I see that a big barrier to being able to be fertile, let alone have a healthy pregnancy. And so in those cases, there's different ways you can increase energy availability, but a low carbohydrate diet is one of those ways. You can increase metabolic rate, you can increase your access to energy by bringing insulin levels down. But what I find is really important in that phase, if someone's wanting to conceive, is don't do a low calorie, low carb diet. If you're going to do a low carb diet and you're wanting to conceive, even if you're wanting to lose weight, it needs to have sufficient energy to keep your metabolic rate nice and high, and it needs to have sufficient micronutrients, vitamins and minerals, because deficiencies in those nutrients can lead to fertility issues and I'm sure complications during pregnancy. How to get the masses to hear that and to be able to achieve that practically, I don't know. But I work with individuals one-on-one, and I think that's a good place to start.
Thank you.
Yeah, organizationally in pediatrics, well, pediatric endocrinology is probably a subset of, you're not really so much into prevention, right? It's more reactive practice, kind of like most internists.
By the time they come to us, they do have diabetes, right?
Right.
We work on preventing long-term consequences,
yeah,
secondary prevention.
OBGYN as a field, there have been some signals where people have been open to that. Well, obstetrics is always known about carbs and looking for gestational diabetes. You get prescribed a low-carb diet if you have that during early pregnancy. I'm trying to think organizationally. There aren't, family medicine. It's more like targeting groups that have that preventive messaging, that audience already there, and just changing the message. And that means finding a super user, I had a med student recently who did lose weight on keto some years ago, but wasn't doing it anymore. And I said, well, it was a resident. I said, well, what did you learn? She said, well, I learned I wasn't hungry, and I could do it. And did it make you more open to the idea that other people could do keto and it would be fine? And she said, yeah, of course. So the more doctors, trainees we get experiencing, there'll be less fear and all, but that means targeting a leadership group even, or joining a leadership group that makes those guidelines. I mean, that's something you could consider doing as physicians or non-physicians, depending on the group. I think that's amazing. It's called upstream medicine, where we get tired. We feel good about saving people's lives, pulling them out of the river. But what if we went upstream and stopped people from jumping in the river, right? So the whole battle of children and families, that perhaps should be a pre-course here. Yeah, although I don't know that there's enough science in that area yet to pull off talks like we've had today. So anyway, that's kind of how do we get something that needs more attention? Sometimes the conference here can bring people together. I think it's a great idea.
Okay. Hi, Alan Schaefer again. Not related to the diabetes, but what you were just talking about. When you mentioned doctor shaming, I had an emotional reaction. So if you can talk more about that. The reason is that since I've been doing this for 15 years, and I know you for longer have had so much pushback and cognitive dissonance from healthcare providers. So what can we do to break through that? And the worst thing, of course, to do is the doctor shaming. And it's sometimes well-meaning, but it just doesn't get through to people. Me being a doctor, I know that if somebody comes to me with a presentation that is compelling, so whether it has data, whether it has mechanistic ideas, so is SMHP or LowCarbUSA or anybody putting together such, if I would love, and I can't do this myself, but like a boxed presentation where I can go to a cardiologist, or I can go to an endocrinologist, or I can go to a family practitioner, internist, and say, this is what we have. Do you have a few minutes? I'd like to go over this with you. So, sorry about the long-winded, irrelevant.
So, but you're projecting that other doctors may feel shame and guilt. No, seriously. I think most of them are happy in their own practice and don't feel bad that they're not doing what you're doing. Right? I mean, so and it's not that they can't feel them personally, but now as my friend, colleague over in Tennessee, Ken Berry, who talks and says has a book, The Lies My Doctor Tells Me. That's not going to win over many doctors. But he has a massive public following for those who like that style, and especially for carnivore-ish. But I don't know. I think the Nutrition Network textbook, Ketogenic, with the egg on it, it's white and red, or white and yellow, is a great start. And so I have, copies of books in my office that, if the timing is right and I have a few extra, I'll hand these out. That one in particular too, but at $150 a pop, it's not easy. Or I don't do that frequently. There are other organizations that fundraise and say they will send books to these pivotal people, based on your donation. If you give $1,000, we'll send 10 of those books to the 10 deans of universities, and I mean it's a start. Actually, no, this other group sent hundreds of books to medical students at a university. It was my nephew who was a medical student there. I go, Peter, what is this on your shelf? It's a vegan diabetes book. And he said, I don't know where that came from. They just gave it to us on the first day of school. And so you can send to that organization a certain donation, and they will send those books to all of the medical students. I'm sure if you're the dean, you're like, well, it's a free book, we'll just give it. And they never looked inside. So I said, well, Peter, let me look. Who knows? Maybe Neil Barnard has my study in there, it didn't have any other studies other than the vegetarian ones. And yet it was pitched as a dietitian or diet book for all doctors. So, but that I think is a strategy, is to send, now that we have that textbook, I'm really proud of it. I'm really happy with how it came out. Although, it's like a Gary Taubes book on steroids, meaning it's hard to read. It's very dense, but it is a kind of a leave behind for researchers or even doctors to persuade them that, wow, there is a lot of science behind this. But now to get them to change their practice, you just tell them there are easy ways to do it, and then everyone has their own barriers. What have you found to be effective in persuading your colleagues, if you've had any?
So I think I want to ask you a different question first. How much education on nutrition did you get in medical school?
Very little. And so this is 1980s, and then in residency I got TPN education. So really my total parenteral nutrition. So if someone's in the ICU, they can't eat or drink, you learn tube feeding, and then intravenous feeding, and then I learned that the food pyramid fixed everything. Well, and I learned from companies.
That sums it up, actually.
I learned that fruit has a lot of vitamin C, and where would you get vitamin C if you didn't have orange juice from Florida here? So we learned from companies that market their foods. So right. How about you? Did you get any nutrition training?
Yeah. So I think, that's one of the first shortcomings, maybe, that nutrition really isn't part of the medical school curriculum usually. So I had almost no nutrition education at all, and then. So
tell you what, you take Harvard on, and I'll take Duke on, and we'll try to get an hour.
So I think that Harvard is a pushover, because David Ludwig has done the footwork for me. So what I will say that I can't say I've convinced a great many people outside of our division, but our division has been very supportive for what I do. What I do is not mainstream, neither the research nor the approach. It's not consistent with the guidelines. So I had worries that, would my colleagues would my division chief even allow me to do that kind of research with our diabetes population, right?
I want to congratulate you on getting NIH funding. That fixes everything.
So I think... So I think we've contended with David Ludwig long enough for most people in our division to be pretty open-minded, for which I'm grateful.
I have to understand choice words. So David Ludwig, thank him, please, in person. I wish he could be here. If you give him an idea, he's the one who got together all of the obesity researchers, from the calories in, calories out group to the carbohydrate insulin model group, and had the idea of, let's get everyone all on the same paper. And so he writes it, basically, we comment on it, make comments. Most of us didn't do much because he put all of it in there. And basically it says calories in, calories out is a tautology. Do you know what a tautology is? Now, this is classic David. Look it up. It means that it's a truism. Of course, it's true. So Gary Taubes is a little less forgiving of the calories in, calories out people. He says, well, of course, the restaurant's crowded because more people went in than came out of the restaurant. It's just not very helpful to say that. So, of course, more calories went in than came out. It just doesn't tell you why. And so David did the ultimate, what a great, I don't know how you say it, diplomacy of bringing together people. So, again, it looks like there's consensus, but the older folks don't. Again, they just didn't really care because they thought, well, we know it causes obesity. It's more calories in than out. And meanwhile, low-carb diets are frequently popular, and diet books all have a low-carb bent to them because that's what works. So anyway, no, but at Duke, at Harvard, at most major academic, at Michigan, the NIH money will allow you to put catheters in people's groins and give them drugs. I mean, you can do all sorts of risky things with governmental NIH money. Here, you're just telling people to eat real food. It's not a risky intervention, and it's about time. I'm really thrilled for you for that.
Yeah, I was surprised. Yeah, I was able to get 2 NIH grants and also funding from the ADA to help do some of the work. And people had told me not to expect that, so maybe the tides are shifting a little bit.
Fantastic. Yeah.
Peter Ballerstedt, Grass-Based Health. It's how can patients reassert the relationship between themselves and their doctor? What sorts of tips could you give someone to kind of get that squared away? I hear about doctors firing patients, but at the same time I hear from patients who say to their doctor, this is what I want to do, can you help me? And these are the things that we'll look at. So it seems to me that the latter is healthier than the former, but the former sounds like it's not uncommon. So just any thoughts along that line?
Jessica?
Well, I mean, I'm a dietitian, not a doctor, but just speaking from my experience, my patients are often admit to me when they see me that, they've seen dietitians in the past and they've almost been scarred from their experience. And, whether that's because they followed their advice or not and had bad results from it, they just see dietitians in general as being a sort of practitioner that can't help. And so I think that, for myself, oftentimes I need to kind of show that, okay, well, I'm different, or I'm going to do something different to what you've tried in the past. And I think a really good thing for practitioners to do is actually ask their patients, well, what have you done in the past? What have you tried? What has been successful? What hasn't been successful, no matter what their sort of health goals are, and listen to them and don't repeat the same thing that they maybe have done in the past that hasn't worked. And that kind of works for me because the first 15 minutes of my consult, I'm often just trying to get people on board because they've been so dismayed from what they've heard from other dietitians. And so I think part of that and part of building that trust is finding out what they have done in the past and not repeating things that didn't work for them. So I guess that's a way a practitioner can help sort of rebuild that trust with their patient.
I think for a relationship of a doctor and a patient to work out, both need to be open-minded, open and understanding, and understand, what are some of the things that a doctor can help with, and what are some of the things that family may know better, right? I'm not at home with you. There is many things that parent knows about the diabetes that I could never even begin to understand. And I think if both parties understand that, those roles and that it's really a team, I think it could be a good relationship. And not all practitioners and not all patients are able to enter that kind of a relationship, which is tough. But that's the type of relationship I try to build with my families. Like, I learn from you, I tell you what I know or what I not know sometimes, and I think that could be a fair.
So it depends on the personality of the doctor. Yeah, whether they're ready, open. In my experience, I persuade other doctors by changing their patients. So that the first one goes through, they lost all this weight. Oh, Westman, right. The second time, third time, they're sending all their patients to me now. Now, why it doesn't occur to them that they could learn the same method that I'm using? Well, they don't know. I think largely they don't know. And most professionals, me included, I mean, when I didn't know, I needed to pretend I knew something, right? You're the authority, right? So have more fruit and vegetables, do the Mediterranean diet, eat less, move more. I mean, these are all the things that don't work, but it makes it seem like we know something. So the patient who has shopped around, been to a lot of different doctors, just appreciates you listening and meeting them where they are and helping them achieve a goal. There are a lot of ways to do that. I don't know why some doctors have it in their ego or in their guideline portfolio that they have to be right about everything. I mean, I think that's more a personality thing. The family meds, there are internists, family medicine doctors, but OBGYN doctors seem to listen. I don't know why. A lot of them come to the obesity medicine world because I think they really want a solution for their patients, and we don't teach solutions for diabetes reversal and obesity treatment in medical school well. Is it incumbent upon us to change this? Maybe a pre-course session on how to change the education of health providers.
Just throwing out there. Okay, we got about 5 minutes left. Let's see if we can get at least one question from the live stream. Well, let's try and see how quickly Eric speaks.
Okay. Dr. Westman, this one is addressed to you about your opinion about how long it takes for someone to become keto or fat adapted.
It depends. If you're otherwise healthy, it may be 1 or 2 days. You can measure it by blood or breath or urine ketones, so you can know exactly for yourself. If you're metabolically ill, it might take a week. It might take 2 weeks. So I've met these are the extreme cases of people, their story is they've been heavy all their life. They were put on Weight Watchers when they were 10. They took 2 weeks to get back into ketosis after one meal, and this was 5 people in a controlled kind of study. So there's a wide variability, and you can measure it directly now. So there's no guesswork if you want to go to that length.
Great, thank you. One more. Is there any evidence to support insulin treatment to support beta cell production and longevity in patients who present with a confusing clinical picture and look like type 1.5?
This is that question of why do you give insulin to prevent diabetes from coming on? It made no sense to me.
It's been studied extensively. It's the concept called beta cell rest, where people are under the impression that some of why the beta cell burns out or stops working is because working too hard and changing the beta cell milieu and making it more prone to autoimmune processes, right? It'll display markers on the surface and make it more recognizable for the immune system, and that speeds up the immunity. I think there is some mechanistic data that has supported that concept, but it has never played out in a clinical study.
Why not just reduce the carb input rather than give insulin to
Well, that's what I'm going to do next. I told you that.
I need to hear it twice, Belinda.
We go back to my last slide.
Yeah, there's too many research studies on that one. Oh, sorry. A little academic wrangling here, sorry.
You got one more?
Yes.
It's going to be quick.
I think so. In children with high BMIs that place them in the morbid adipose, do they have increased adipocyte hypertrophy, which protects them from insulin resistance and delaying type 2 onset?
I have to be honest, I haven't kept up
I-
on that mechanistic kind of literature. I'm more a fixer.
I'll say something philosophical about that. I think, adipose tissue is really what protects us from nutrient excess, right? If we weren't able to build a lot of adipose tissue and eating the way we do right now, we would all have diabetes and be dead, right? Like it's lipodystrophy, where patients do not have the ability to hypertrophy or build adipose tissue. They get diabetes and complications at a very young age, have very high mortality. So fat tissue and adipose tissue is really kind of a safe storage for the extra energy we intake. So yes, it does protect us from diabetes.
Yeah, that's been the personal fat threshold concept that hasn't been, it's hard to test exactly. But I think we're going to hear about this in Rob's lecture coming up, so hang on. Jessica, any thoughts, Jessica? Don't want to exclude you.
I don't have anything to add. I completely agree. I think it protects us.